Alright guys, welcome to Black with Vascular, channel where we use real life examples, day-to-day stuff that happens in the hospital and teach you about vascular disease. We're going to keep things simple, clear, easy to understand, focus on the arteries and veins, and it's all free medical education from a board-certified vascular surgeon. If you need your own advice, go see your own physician or board-certified physician of some sort. If you like the videos, like and subscribe, and if you have questions, email me at blackwithvascular@gmail.com and I can make you a video of your own. I hope you enjoy the video. Thanks. Hello everyone and welcome back to Black with Vascular. Today I'll be reviewing this network meta-analysis to compare, which was performed to compare Venaseal with other therapies that you could be looking at getting treated with as a patient. So people always talk about which of the procedures is the best, and that's such a simplistic way of looking at it, but it's an honest question and it deserves some sort of honest answers. And I'm going to keep reading articles and studying and trying to explain what we find from the data that's currently out there in a way that you guys can understand. So I guess one of the first things we should do is talk about, when you look at data, there are different types of studies that exist, and some studies are strong in the form of a randomized controlled trial, blinded randomized controlled trials, and for those people who are not statisticians, you may not understand all of these different terms. This article specifically is not the strongest, but it is very strong. It is a network meta-analysis. A meta-analysis is a situation where you take a number of different clinical trials that other people have done over time, and pool all the numbers together to get a more powerful estimate of how the treatment performs. So for in this case, we're looking at Venaseal, and you might want to compare Venaseal to laser, or Venaseal to laser and radiofrequency ablation, or Venaseal to foam, but you may not actually have enough numbers. Some people may have done a study with only 50 patients, but that might not be enough to prove your point that it's a good treatment or it's better. If you only have, let's say, an adverse event like an allergic response happening every 1 in every 100 cases, then you won't be able to show, without 1,000 patients, any sort of meaningful data between two different types of therapy. These are just examples I'm giving. So in this case, is a network meta-analysis where they didn't just do A versus B, like Venaseal versus radiofrequency ablation. They did A versus B, B versus C, C versus D, and then they use different complex statistical algorithms to indirectly compare the treatments that were never ever tested head to head. So this way you may be able to compare two different things that were never tested in an actual real world trial head to head by inferring, by trying to guess based on how it performed to something else. So data essentially is extracted and analyzed using what we call a mixed treatment, different types of treatments comparison in a network meta-analysis. So for me personally, as I read this network meta-analysis, I just want to give you guys a general summary of what it is. This article is a company-funded network meta-analysis, meaning that the people who are selling the product to the patients and physicians and hospitals who are meaning to profit, do this as a way to prove that their product is good, right? It's not a disingenuous way to do things. It's just the way how things are done these days. It's hard to actually sell your product unless you prove that it actually works. In order to prove that it works, you need studies. In order to study it, you need funding. So in this case, the people who are meaning to gain, Medtronic and their team, actually fund an article and a study where doctors sit around and gather all these older studies together, these different studies that they looked at through the Cochrane and PubMed databases of previously published studies, and then they do an analysis of everything to prove the point that Venaseal, gluing the superficial vein, small saphenous or great saphenous vein, is not worse, or it's actually acceptable, or it's something that could be done, or maybe it's even better than radiofrequency ablation, laser, and the other treatments like surgery that are out there. So what did the entire study conclude? If we could just put one simple idea together. Well, what we found in this article, what they found in this article, what I'm telling you now, is that Venaseal, gluing the vein, had the highest success rate at 6 months and the lowest rate of side effects and adverse events. Now, I'm not saying that's the actual truth. I'm just saying that that's what this study found. This study, funded by Medtronic, the company who's selling the glue, found this. And I think that's reasonable. It could be that it's absolutely 100% true, but this is how you have to become a doctor who thinks clearly. And as a patient, you have to be educated and think about the results. It doesn't mean that it's a conspiracy theory. There's this tendency to just kind of say, well, they paid for it, so therefore it's already not true. That's not a very mature way to think about it either. You have to think about it logically and with nuance, and think about the fact that thousands of people are getting these procedures and having good results probably these days. So clearly we're not doing things to hurt people and just trying to sell them something that doesn't work. But there's nuance to everything in life. And in this case, the treatment of the saphenous vein is no different. You cannot just say, okay, Venaseal, gluing the vein is better than laser. Laser is better than surgery. Laser is better than Venaseal. It's not that easy. Otherwise, everybody would tend to just pick one treatment option only. The other thing that it found, and again, it had the highest rate at 6 months, but it didn't tell us what the rate is at 6 years, because they didn't study that. And we know that things change over time for these treatment modalities, but at the 6 month mark, which is really early in my opinion, Venaseal, the gluing, was the best. And in terms of quality of life, in terms of how well the patient felt clinically, like how actually you feel, are you happy with your treatment, it was similar. Not superior, but similar. The other thing to note from this study is that the evidence that we currently have is very limited, because the studies that they had to study were limited. They were heterogeneous, meaning that, or heterogeneous, I don't know how you pronounce that, but either way, they were all over the place. So you can't really directly say with 100% certainty this was a clean study where they studied A versus B, and like everything is just clear that whatever the outcomes that we see from the study, they're not very clean. You have to rely on a lot of indirect and guessing to kind of get to the best answer. And that's 2020. So 6 years later, I don't think the data has gotten much better than this. It's not like people just have money to just keep redoing studies. If the thing is performing well in the community and in society, for the most part, we just start using it, adopting it, and the FDA clears it and people move along. Unless something is clearly, new that pops up, I don't think they're going to be restudying Venaseal over and over again with new head-to-head trials. So sometimes the data never ever matures, never ever really gets really good. Maybe get matured in terms of age and longevity, but not better quality studies, right? Does that make sense? Hopefully it does. All right, so what else can I tell you about the study? So in this study, they had between January of 1996 and 2018, they took a whole bunch of studies from the Cochrane database, and at the end they whittled them down to 20 randomized controlled trials with 4,570 patients. And then they did their complex statistics and blah blah blah. The main outcome was anatomic success. So the main thing that we're trying to figure out is it going to glue the vein? Is it going to shut down the vein, the saphenous vein, as well as the other ones? And the answer was yes, it did. It had the highest probability of being ranked first. EVLT, when you compare it to when you compare each one to Venaseal, EVLT was 62% as effective at 6 months. MOCA, meaning ClariVein, the wire that whips around in the vein, was 75% as effective. Radiofrequency ablation, 63%, similar to laser. Sclerotherapy, 92%, which is surprising to me. So I'm wondering already if that was because the Varithena and sclerotherapy cases were little tiny, dinky, easy saphenous veins to close. Meanwhile, the lasers and the RFAs, which are actually known to be the best at treating the hardest, biggest veins and with the longest data, why would they performing only at 60% compared to Venaseal? So probably you're looking at trying to close up a 12 millimeter vein. Meanwhile, with the sclerotherapy cases, you're closing up a 3 millimeter vein. So yes, sclerotherapy might have 92% closure rate at 6 months, but we don't know for sure all of that data. At least I didn't really gather that. And then finally, surgery was similar to laser and radiofrequency. 6 months, everybody had a closure rate of about 62 to 92% of Venaseal's closure rate. The part of one of the things to remember is that the Venaseal actually had their own initial randomized trial called the VCLOSE trial, VECLOSE, and a lot of the strong data came out of VCLOSE, which was a Venaseal versus RFA trial, which had already showed non-inferiority. So this network meta-analysis already drew from a previous Venaseal trial. So you can see that there's bias within bias sometimes. Anyway, what are the other outcomes that they looked at? They looked at the VCSS, which I have a video on, where we talk about the clinical severity, ranking things such as pain, swelling, skin changes, the use of compression stockings on a scale of up to 30, and we go with severity of how bad your vein disease is. So when they looked at the VCSS, you try to figure out how does the VCSS change after your treatment with the procedure. Does it get better if you've treated somebody who had a score of, let's say, 25, and then afterwards they come back with less pain, less swelling, less heaviness, the itching and the ulcer heals, they're wearing compression stockings less, all of a sudden their score has dropped. How severe their vein diseases has improved. Well, what they found was that when they look at the VCSS score, Venaseal is in the middle. It's ranked number 3. In order of best to worst, the superior treatments were radiofrequency ablation and MOCA, and then less, or I should say, RFA was better, but but Venaseal was better than surgery and sclerotherapy and laser. They also had other things like the EQ5D, which is another health-related scoring, and the Aberdeen varicose vein questionnaire, where the patients actually answer their own questions. And again, Venaseal was kind of in the middle there. So it wasn't like, oh my goodness, once somebody had a Venaseal procedure, they were like, wow, my vein disease has improved so much more, blah, blah, blah. It was kind of like, it was in the middle. RFA was better for AVQQ as well as MOCA. Laser, sclerotherapy, and surgery were not as good as Venaseal. When it came to pain, just pain alone as a finding, Venaseal was number 1. Laser, sclerotherapy, surgery, and radiofrequency ablation all had less pain reduction than Venaseal. And I think part of that is the Venaseal procedure is very minimally invasive when it comes to the minimally invasive procedures. I'm a little surprised that sclerotherapy had so much pain and didn't end up more. Sorry, pardon me. I'm surprised that sclerotherapy didn't show up as a better option, because sclerotherapy also is a very minimally invasive approach within the minimally invasive space as how to treat these veins. But in either case, the point is that Venaseal is definitely one of the least painful ways to get your varicose veins treated. Adverse events. This one I was a little bit shocked at also. The Venaseal once again had the lowest adverse events. You had 3 times as much adverse events with sclerotherapy, 2.7 times as much with laser, and 1.6 as much with surgery. And I don't think RFA was very similar, 1.1 to 1 times as much. So it's more or less 1-to-1 with RFA. But I'm surprised. But I think that a lot of that again was because how you define adverse events is very variable. Some people might say if you had darkening of the skin where the reticular vein is, that's hyperpigmentation, and so therefore that's an adverse event. Okay, so sclerotherapy has all sorts of adverse events, but that's because you're treating all these superficial side branch veins, right? Which is over time, a year later going to all lighten up and improve, and then maybe you don't even consider that adverse event. Maybe that's actually a positive. Whereas when you Venaseal the great saphenous vein, you may not get glue shutting down every single side branch, whereas sclerotherapy seems to just, the Varithena foam goes everywhere in the superficial veins. So what could have been an adverse event in Varithena could become a positive later, but for Venaseal it's a negative because, I guess it's not an adverse event at the beginning because it doesn't treat the side branches as well. It shuts down the side branches by shutting down the flow of reflux through the main vein, but even so, it doesn't make sense to me that the adverse events are lowest in Venaseal. Venaseal also has a risk of allergic responses, which I don't really see them addressing here in this study. What else can we talk about? as I went through this study, I think the key things I would say is that the study is funded by Medtronic. Several authors were paid. NN, BBB, TJ, all were paid by Medtronic. Doesn't invalidate the findings, but it definitely makes you think twice, especially given all these pro-glue conclusions. And don't get me wrong, I love Venaseal. I use it all the time. But it makes it, I try to be as objective as possible when I give you guys information. The study type itself is limited because of the fact that they had to pool data, and you had to kind of analyze time points that were available. So if one study had studied patients at 1 month and 3 months and then 6 months, but the other study had studied somebody at 2 weeks and 6 weeks and then 6 months, you had to kind of guess and kind of try to match up those numbers. So it's not really the best, cleanest trial, as I said before. Again, the follow-up period is relatively short, only 6 months. Because it wasn't a clean trial, there was, if people were doing laser, some people use laser at different joules, different wavelengths, different RFA devices and types and sizes of sheaths, different formulations of sclerosant. Some people use 1%, some people use 0.5%, some people use 1.5%. So how do you know it was clean? It wasn't standardized. So it's not a clean apples to apples comparison, and that's why people ask for proof, but it's sometimes physicians can't find the exact proof. We can give you some idea based on what we know, but we can't always answer everything perfectly. When it came to the MOCA study that they studied, they had 2 MOCA trials that they looked at. And the MOCA trials were very kind of didn't have a lot of the outcomes. So it's very unreliable to even discuss MOCA. Which is a combination of wire that moves around in the vein and kind of damages the intima, the inside of the vein, while injecting Varithena, which is a caustic detergent sclerosant that burns the vein also. We know that when you follow patients for years, some veins recanalize, and that there is some divergence between the curves and the outcomes across different devices and surgery. So therefore, this analysis is very limited in that it doesn't address anything past the 6-month period. You cannot make any assumptions in science about what will happen at 6 months. It could be that something that's closed at 6 months with 92% certainty then reopens at 6 years, more likely than something that was less likely to be closed at the 6 month, like with laser or whatever. We can't make any conclusions after 6 months. We just know that in the first 6 months, this study showed that there was a better likelihood of the vein being closed. When you strip away everything, it's not inferior to radiofrequency ablation. It causes less pain and fewer adverse events than most of the other procedures like laser and RC and radiofrequency ablation and surgery, simply because, again, you're not doing any tumescence. Has a great 6-month closure. Long-term durability still being defined. Quality of life and how well you do clinically after, when you came here for actual symptoms of heaviness and pain and achiness and all that, it's similar, not superior. And this is a heavily influenced study based on indirect comparisons and industry sponsorship. So hopefully that gave you guys a good understanding of at least one study that we could read about and learn about. And you could think about some questions. One question I had in my mind, which just in my mind, I was thinking, why would Venaseal be superior in terms of pain and recovery, than, like, why would Venaseal be superior to surgery and sclerotherapy, but inferior to the others? So surgery seems invasive to me for more invasive disease. Sclerotherapy seems more minimally invasive for less problematic disease, like a smaller varicose vein in general. So why would it be better in terms of, when you looked at the clinical severity score, how much it dropped, why would it be better than those two, the worst and the best, but inferior to the ones in the middle? You know what I mean? Like, patient who had a VCSS score of 7 and got a sclerotherapy, or a patient who had a VCSS score of 25 and had a surgery, a high ligation or stab phlebectomy. Somehow Venaseal was better than those two. Maybe because the 7 moved from a 7 to a 7 or 7 to a 6 after the sclero, whereas the surgery went from a 27 to like a 15, and Venaseal would go from like a 27 to 12 or 7 to 4. I don't know. I can't really fully figure that one out. Whereas when you actually compare it to other procedures that are along the same line, serious vein disease, with relatively high scores, it may not actually show any significant improvement to radiofrequency and MOCA and laser. Venous clinical severity is a composite score, so you're trying to measure the pain, the edema, the skin changes, the ulcers, everything, and the differences between treatments might be small, and so you might not see the big difference. Yeah, I don't really know. I'm just looking here to see, but I think maybe patient selection might be different in these trials. There may be different follow-up and timing between these different studies. The authors don't really show why. They just kind of report what the ranks are. So basically, Venaseal sits in the middle, better than surgery and sclerotherapy when it comes to clinical severity scores and how it improves you, but not clearly better than RFA or MOCA. Differences are small. Statistics show association, but not a clear causal, kind of like causation story. There's no real reason as to why it's actually better. When it came to pain, by the way, the pain that we talk about was mostly in the first 2 weeks. Laser, sclerotherapy, surgery, and radiofrequency had more pain in the first 2 weeks than Venaseal. So it's really the early post-operative pain that they studied in this article, the first 2 weeks of pain. Adverse events, by the way, which we said was so much lower, right? They looked at things like your skin darkening, bruising, itching, skin irritation, rash, phlebitis, meaning that inflammation around your vein in the early couple days, numbness and like kind of tinglings around your leg, wound infections, blood clots in the deep veins, blood clots in the superficial veins, groin infections, and pulmonary embolism. All of these things are considered adverse events. So it's a very wide range of adverse events. Sclerotherapy randomized trials, they always go down to like the nitty gritty. They report every single little thing. A person developed a bug, a little pimple, they report it as a complication. Meanwhile, surgical trials, they don't report minor events at all. They just focus on like, oh, this person didn't have a DVT, that person. So it looks very, very different, across these trials. And then you kind of lump all these together, you might not get a true picture. So I wish we could say the adverse events really were lower, but I think it requires a cleaner randomized trial, really, where you study Venaseal, RFA, laser, and MOCA, as well as surgery, all in the same group of patients, all having the same thing, and look for specifically for adverse events and define all the adverse events the same. That would have to be done before you could actually come up with an answer. Is there anything else that we can talk about? I don't know. I think that's a pretty good thing. One thing I wanted to mention, which the paper did not talk about, is they did not discuss type 4 delayed hypersensitivity reactions. That's like poison ivy, idea. They didn't discuss contact dermatitis. They didn't discuss the idea that the person might have a glue allergy or foreign body granulomatous reactions, which is when some of the glue is injected outside of the vein into the soft tissue and dermis, and then becomes like a hardened bump that actually can have a very inflamed reaction. They didn't discuss any sort. So I'm sorry about the video shutting out just a while ago, but just to finish and summarize this, I think my biggest concern, which I think I've heard echoed over and over again by multiple different people, is this concept of the allergenic response of glue to each patient. I think that every patient has a small degree of allergic response. I definitely think that there are different types of allergic responses, such as hypersensitivity reactions, dermatitis, and other types of inflammatory responses that can happen. I think that when we have a randomized control trial like this, where cyanoacrylate allergy, which is the biggest concern of many physicians, it should be addressed, and there should be some number of allergenic numbers and skin lumps and all these kind of things that should be mentioned and discussed. So I think it's hard because these patients with itching and pruritus and a red vein afterwards, that's not an infection, which get better with Benadryl or steroids. I mean, okay, maybe they're not a severe allergic response, not like the terrible examples that you hear of people having to have their veins excised, but I do think it's big enough of a concern that we should talk about it, because that's the only things I talk about with my patients who I'm going to be doing glue treatments on: DVTs, blood clots, and allergic responses. So I'm, in any case, if you like these videos, follow along, like and subscribe, and help me get to the goal of 1,000 viewers. And I'm just making a bunch of videos for free at this point, and continuing to share education to you guys in a way that it makes sense for you to understand, and answering many people's questions at the same time with these videos. So these are all things that we cannot discuss in a 10-minute conversation in the office, and you will never get that information from a physician unless they're your personal family member. So for right now, it's all free. Just follow and like and subscribe and help the algorithm push it.